Hi, folks. It's hard to know where to look. We'll look right at that post. I'm Stephen Bornstein. I'm the director of the Newfoundland and Labrador Center for Applied Health Research, which, as you will see in a second or two, is a very appropriate acronym for tonight's event. NLCAHR. Unlike the actors who win all those Emmys and other things, I'm going to look at my notes because I can't remember a damn thing unless I do. So, on behalf of the Center for Applied Health Research, I'd like to welcome you to one in a series of the programs of guest lectures that we call Research Talks, or Research Talks. I'm not sure actually how to say it.
Or Research Talks.
Research Talks.
Yeah,
Research Talks. Or Research Talks. Okay. Speakers for this series are either directly selected by Rochelle, by us at the center, or more commonly we get one of our research exchange groups, of which we have, I think now 12, going on 14, to take turns, pick a speaker, find somebody good, and then help us figure out a program and find funding to bring people in. This time it was the turn of the research exchange group on gender, sexuality, and health. And its convener, Nicole Power, who's over there, of the Department of Sociology, had an idea and we decided to run with it. It works out very nicely because the timing is perfectly coordinated with the major conference that's here on HIV, the CAHR conference, and the acronyms match up very nicely, so we didn't think we could say no. We got funding for this and support from a number of sources. The reason I have to say this, otherwise I'll forget somebody and they'll get mad. We got what's called Quick Start funding, which is a small seed grant from Memorial's relatively new Office of Public Engagement. We got Eastern Edge to act as a venue, which is both totally inappropriate and totally appropriate. Makiki having been involved long-term, a number of years ago with Eastern Edge, and he's about to have a show here sometime in the current calendar year. So this is actually a very good venue for him. We got support from a number of community partners, particularly the AIDS Committee of Newfoundland and Labrador, ACNL, and the Make It Better Newfoundland campaign, whose founder, Dr. Ailsa Craig, who also is from sociology. There's a plague of, and what do you call a bunch of sociologists?
They're committing sociology.
We're a murder of sociology.
Yeah, okay. Is here to introduce the guest speaker to the one or two of you here who may not already know him or of him. So, over to Ailsa. Doc.
All right, glasses on, paper out. Thanks so much for coming. I'm really glad to see people here, even the people who I can only see through the loops. But that's quite lovely too. Makiki's a queer video performance artist from Newfoundland. They attended NASCAD at Concordia before returning to St. John's to work as programming coordinator at Eastern Edge Gallery. They later moved to Calgary to work as the director of Trek Gallery, and their work has been presented throughout Canada in self-produced interventions, artist-run centers, and public galleries. Their practice and political history informed a shift into sexual and reproductive health education work around 2003. Makiki's since worked as a sexuality educator in Calgary's public schools, a bathhouse attendant in Saskatoon, drag queen karaoke hostess in St. John's, all of which informed their work in gay men's health. And Makiki's worked as gay men's sexual health outreach worker in Ottawa, HIV educator in Montreal, the Pause Prevention Coordinator at Toronto People's AIDS Foundation, and now runs a street outreach team for a community health center and conducts HIV rapid testing. Makiki's art practice continues with interest and investment in looking at gayness, AIDSness, and dragness. I am personally thrilled to be here, to finally meet the person who everybody I know in Toronto says, oh, you must know Makiki. And everybody I know in Toronto says, oh, you must know Makiki. And we just met day before yesterday.
Yeah,
It's about time, right? So I'm really glad to be here. I'm really glad to see this talk, and I'm really glad that you can all join us. So thank you so much.
Hi everybody, thanks for coming. I'm going to stand directly in the light, likely. Thanks for that great intro, Elsa. I was really excited to get to come and present some new information that we have been talking about in Canada for a little while, related to gay men's health, and when the opportunity to talk about gay men's health and new research that's kind of come out around HIV transmission presented itself, I was really excited to get to come and do this at home. It's not very often that I get to kind of bring some of the larger conversations that are happening in the gay men's health movement back to the communities of people that I care about in other places that I've lived in the country, but this one is definitely the most dear to me. So I'm really glad and appreciative to be here for this. So the talk is called Strategic Positioning. I will get to an agenda, and maybe we could go to the next slide. So dun, dun, dun. So we'll crack a couple of jokes tonight. When people able to see, I feel like I'm standing actually directly in the wrong spot for the majority of people that are there. Maybe I'll stand on this side, although I know it's...
There is no right spot.
Yeah.
It's all strategic position.
It is all strategic position. So the title actually comes from a harm reduction and risk reduction strategy that specifically that gay men and other men who have sex with men have been using around reducing the likelihood of HIV acquisition or the likelihood of getting HIV. And we'll talk about that and some other things in kind of item number 6. I was hoping that we could go over some language and terminology that I realize have become kind of commonplace and daily for myself, but aren't necessarily commonplace in a lot of conversations with gay men that I see that don't necessarily work in the AIDS service organizations or in the HIV sector. We'll do a little bit of epidemiological background, or like just talk about like, hey, what's been happening with HIV and gay men in Canada, just so everyone in the room kind of is coming from the same starting point. We'll talk a little bit about the history of HIV prevention, talk a little bit about the history of HIV treatment, and then we'll get into the juicy stuff, which is there are 3 studies that have come out in the last 3, I think, or 4 that we're going to talk about tonight that have come out since 2008. I think 3 are studies and 1 is a position statement. So we'll talk about what those things are and what they mean to HIV treatment and also to HIV prevention, because there's some implications in both of those realms. And then we'll talk a little bit about harm reduction as an idea and harm reduction and how it plays out in sexual and reproductive health management. I wanted to kind of end with some of the complicated kind of problematizing these ideas of some of the benefits that we'll see from these new research studies, what we're already seeing in Canada around the criminalization of HIV. I think that there's definitely a role that research plays in this. So we'll talk a little bit about ideas of personal responsibility and criminality. And then, because I think it's irresponsible of me, speaking of responsibility, it's irresponsible to leave the room as on a downer note, so I would actually like to talk a little bit about what are some things that we can do in the room, and what are some things that we can kind of require and request of our political leaders and also of research moving forward. I'm really hoping that I won't blast through this. I have a tendency to talk very quickly, especially when I'm excited about things, and I'm really excited to be here with you. But I also want to ensure that there's some space for questions. So what I would like to suggest, and feel free to challenge me about this, I'd like to suggest that if there are like point of process questions, or like I'm not able to kind of understand what you're saying, or you said it too fast, feel free to flag me and stop me. But if you want to get into a discussion about some of the content, if we could save those questions until the end, does that sound reasonable for folks?
Yes.
Awesome. That's great. I'm not going to ask if it's unreasonable for anyone then, because then we'll just have to talk about that. Would you mind skipping to the next slide, please? It's easier to build consent when you only ask one question. So I'm going to go over some terminology that we use. So in research world, specifically when we're talking about HIV and HIV prevention, the language that often gets used is MSM, or men who have sex with men. So when we look at some of the epi data that's coming out of or like epidemiological data that's coming out of the Public Health Agency of Canada around HIV and gay men, we see gay men referred to exclusively as men who have sex with men. So I wanted to mention that. So if you do some background work or are interested in looking some of this stuff up on your own for your own research or your own scholarship, or just out of prurient interest, you'll see MSM used as a stand-in for all men who have sex with men. The reason that it became a term so commonly used is because there are a considerable portion of men who are having sex with men that don't identify or disidentify from being gay or queer or bi, that would identify as straight men that just happen to have sex with other men. And we were recognizing in the HIV response that we were not capturing, like we're on the hunt for these people. We were not capturing these men in the inquiries that we were participating in about where people were getting HIV. So it's not just about how people identify, but also just about sometimes people have other sexual practices that exist outside of their identities. There's been a little bit of pushback, and I just want to also acknowledge that a lot of us are actually really comfortable and identify as gay or bi or queer on purpose, and think that it's actually really important to take up space with an identification like that. I'm not just a man who has sex with men, I'm a queer identified person, and that the state would impose a label like that, and a health agency or health research agency would impose a label that takes away that part of my identity and just says, oh, you are the same thing as someone who doesn't identify, who doesn't have a culture and a history around your sexual orientation. So there's been a lot of actual pushback from gay, bi, and queer identified men in the HIV response. So I just want to kind of offer that as well. Just a quick definition for HIV and AIDS. HIV is human immunodeficiency virus, and AIDS there's actually multiple definitions depending on where you're located geographically. But in Canada, an AIDS diagnosis is precipitated by you have to have HIV, first of all, and then you have to have an AIDS-defining illness. Folks might have heard of opportunistic infections, like the history of HIV response. So like often we're talking about Kaposi sarcoma, which is a rare type of skin cancer, or PCP pneumonia. So in the history of like the defining of AIDS as an illness, it was historically limited to, or the definitions were linked to illnesses that only men got. So women would get invasive cervical cancer as a result of being infected with HIV and having like no immune system anymore. But that was never able to be defined as an AIDS-defining illness for a number of years. So there was a great poster campaign that happened in the States through ACT UP called "Women Don't Get AIDS, They Just Die from It." So just some interesting history to kind of pepper the talk. Epidemiology. I guess we've got some epidemiologists that are probably going to ask me about what my sloppy definition is, but basically it's just around tracking disease and tracking illness in populations. Prevalence is, I always screw these two up, so please someone challenge me about this, but I just want to make sure that we're all on the same page. But prevalence is essentially looking at the amount of illness or disease that's kind of within a population. And incidence would be when you have, like, say, a year, and like these are the number of people that we have kind of tracked within that year. Tell me if I got that completely wrong. All right, thanks, kids. So the next is antiretrovirals. So we refer to them often as ARVs within the HIV response. That also, kind of interchangeably, we're talking about highly active antiretroviral therapy, or HAART, H-A-A-R-T. And often we also just call them meds, because it's a lot of acronyms, and a lot of acronyms that get collapsed into words that aren't really words. So ARVs or HAART or meds, if I use any of those interchangeably, it's because they're essentially interchangeable. We'll talk a little bit more about what they look like when we get to the treatment slide. Have folks heard of CD4 count and viral load before as terms that's been thrown around when we talk about people living with HIV? So CD4 count is it's one of the tools that we use to measure someone's immune system or immune response when someone's living with HIV. One of the hilarious things is that we don't ever do a baseline CD4 count. So it can cause a lot of anxiety for people living with HIV when they get their first CD4 count done. and then have to figure out if their immune system was actually like, is it great because it's really high, or is it because I'm positive that it's really low, or is it that I just had an immune system that was like anywhere in between? There's actually like a wide range for folks in terms of what would be like a normal CD4 count. But also with viral load, that is another test that people living with HIV would get basically every 3 months when we go visit our doctors. And viral load is essentially measuring the amount of virus that's present in one's blood. And people have, like, and moving down the slide from it, people have heard of the term undetectable before. Maybe a couple people have. So undetectable actually refers to the amount of virus in your blood, and the instruments that they use to measure viral load. In Canada, I think they can only read over 40 copies of the virus per milliliter of blood.
20 here.
20 here? Oh, well that's pretty great.
New machine.
Yeah.
Last 2 years.
Wow, that is a new machine.
We can talk a bit later about whether that's great or not.
Well, yes, yeah. I mean, great new machines, implications in terms of people's real lives, also,
How much
completely.
meaning does it have between 20 and 40?
Yeah, well, let's ask the courts. We'll get into that later. But essentially, an undetectable viral load is being used interchangeably, and I would say potentially, or I would say definitely problematically interchangeably, with a suppressed virus, or folks having achieved viral suppression. So I think that they're often used interchangeably, and we can talk about why that might be a bit problematic. But essentially, an undetectable viral load is a key marker for a lot of health-related issues for folks living with HIV, and also, unfortunately now, legal and criminal-related issues for folks living with HIV. Last two terms, condomless sex. So the CDC in January had just decided that they are not using, the CDC is the Center for Disease Control in Atlanta in the States. They are not using the term unprotected sex anymore because, and through a press release that they put out, they're acknowledging what a thing that a lot of us, I'm just going to say I've been using condomless sex for a lot longer than January 9, 2014, but that they're saying that that they're acknowledging that sex without condoms isn't inherently risky, and that there's thinking about what we are protecting ourselves from, that there's that it's a more complex landscape when we're talking about sexual health management than just use a condom every time, and that condomless sex actually is a less value-laden term than unprotected sex, and I think it just actually reflects more accurately in the conversations that we're having around sexual health management. The last term is treatment as prevention. I've been given a lot of flack for even repeating it. There's a lot of people in my friend group and in the HIV response in Toronto and across the country that think that we should, that think a bunch of strong have a bunch of strong feelings about this. Some of them are folks that are really excited about the public health benefit of putting a lot of people on HIV treatment and then seeing what that does in a good way about reducing HIV transmission. We'll talk about how that could happen. Other people are really concerned about the potential ethical implications of people feeling like they're forced or strongly encouraged or cajoled to start treatment that they might not be ready for, and would have potentially significant health impacts if they're unable to adhere and maintain adherence or keep taking their medication in a regular way. Could actually have significant health impacts for a person individually, and also in terms of community level health impacts. Next slide, please. Are folks okay with those terms? I know I kind of barreled through them, but we'll go through them again, and as people need me to clarify, I'll just do that. So yeah, this is the clunker slide that we'll just get out of the way, but it's just to talk a little bit about, for those that don't know, gay men have been disproportionately affected by HIV in Canada. We could basically just click the slide, but we won't do that. But I'll just talk a little bit, I'll just go through these really quickly, but I didn't want to elaborate necessarily so much on them because I think they're pretty self-evident. So by the end of 2008, an estimated 48%, or 31,330 of all prevalent HIV cases were attributed to the MSM exposure category. This is in Canada. An estimated 1,480 new infections, or 47% of new infections, were attributed to men having sex with men in 2011, as compared to an estimated 1,470 new infections, or 44% in 2008. So we're essentially seeing new infections amongst men who have sex with men have basically stabilized, but I don't think that 1,500 to 2,000 a year is stable in a way that I'm comfortable with in terms of new infections. So we're also seeing, I don't know if I actually have this on the slide, but we saw in 2008 young MSM, or young men who have sex with men, young gay men, were they were the top of the charts for new HIV infections in Canada. So we're seeing, that gay, bi, and queer men are very disproportionately affected, hover around the 50% of all HIV acquisitions and all folks living with HIV in Canada. So again, this is just more stuff that kind of reiterates it. I'll just say it for the folks that can't see the slide in the back. So an estimated 19% of HIV infected gay men in 2008 were unaware of their HIV positive status. So I want to also just flag this because this, I think, is actually a good thing, because when we say it's hovering around the 20% mark of gay men living with HIV or who are infected with HIV are unaware of their status. When we talk about the general population of folks living with HIV in Canada, that average actually is up higher. It's between 25 and 30%. So this, I think, is a really good indication of gay men taking care of our sexual and reproductive health, taking care of our partners, going and getting tested. I think that it's access to testing in gay male communities, specifically communities of gay men that are out and comfortable identifying within gay and queer culture, tend to have more access to HIV testing than a lot of other communities. Cumulatively to 2009, the MSM exposure category, or gay men's exposure category, accounted for 66.3% of positive test reports amongst adult males. So that's some pretty significant numbers. And at the end of 2009, the gay male exposure category accounted for 74.9% of cumulative reported AIDS cases among adult males. So that's recorded. And that's a thing. That's a thing in my community and in my life. So this is one of the reasons why I think it's really important for gay, bi, and queer men to take up some space in the HIV response and say, actually, there's been a lot of really great work done, but we also still need to take up space for gay men and gay men's health and have conversations about what are the actual realities of the sex that we're having, what are the prevention strategies that we're applying, how are we building community, and how are we supporting people, and then is that working or is that not? How can we do that better, and how can we demand support from other people when things, I would say, structural and institutional barriers are getting in our way. Next slide, please. Okay, so I just wanted to put this up. It's the inside cover of How to Have Sex in an Epidemic by Berkowitz from 1983. So also a quote from Susan Sontag, Illness as Metaphor. She then wrote AIDS and its metaphors a little while afterwards. I'm not necessarily going to get into some of some of the issues I have with some homophobic comments that Susan Sontag made in AIDS and its metaphors. I'll just leave that put that in the room. Can we get to the next slide, please? So I just wanted that slide to kind of demonstrate that. So that was a publication from 1993. It also had a doctor as a co-author who was there as a medical expert to kind of help build how do we actually formulate safer sex in the age of AIDS, and also just to acknowledge that queer communities and gay male communities actually helped to invent safer sex. And there's I've got some data to confirm that in my notes. But one of the things that was really important around the initializing of the AIDS epidemic was this rallying of not just gay men supporting each other, and we definitely see that a lot. When I first became involved in the LGBTQ movement in St. John's and started volunteering for the AIDS committee when I was very young in the mid-90s, it was also a lot of queer identified women that were part of the response. We saw that here, we also saw that in larger centers. So it was that LGBT people and queer people started caring for each other, and I needed to put down in different ways. We were caring for each other before, but it was also really easy to silo and I'm just going to say I didn't live through this as an adult, so I'm taking this anecdotally through a lot of my older friends that were members of the queer communities here in St. John's, but also in Montreal and Toronto and Vancouver and Saskatoon. But the relationships that were formed as gay men were getting sick, and the queer women that were also helping to participate in organizing a response. And that was in terms of providing care for people that were ill, but it was also in terms of thinking about how we can gather together and demand an institutional response. And that's what happened. So there's what is the history on that? Sorry, I've got some stuff around that. So yeah, just to kind of mention, so it was 1986 was when the Newfoundland and Labrador AIDS Association joined the Canadian AIDS Society. So Newfoundland has actually been like active in the response, in the HIV response for like close to 20 years now. So I think it's important just to acknowledge that. It was also 1988 when the Canadian AIDS Society developed their first transmission guidelines for HIV and hepatitis C in Canada. And interestingly enough, and I'm wondering if maybe some folks in the room might have some information on this, when I was doing some research for this presentation, I was really surprised to find that the Newfoundland government has taken AIDS as a reportable illness off of the reportable illnesses registry as of 2009. So we have 100 reported AIDS cases up to 2009 in Newfoundland, which is, given its size, like a reasonable, unreasonable number. I think that when we also think about outmigration and so many, like these were AIDS cases that were diagnosed within Newfoundland. When we think about all of the LGBT folks that didn't feel comfortable, especially if they were getting sick, or having all of their friends around them get sick, there were a lot of people that were the gay parents of folks my generation that went to Canada and weren't seen as Newfoundland diagnoses. So I think it's important to acknowledge that there's also a huge swath of gay men, gay, bi, and queer men that are missing from the data that's reported about who got diagnosed and who was treated and passed away in Newfoundland versus who of us left to go be in a larger community with better access to like current treatments. So I just wanted to kind of flag that. Could we go to the next slide, please? So this is just a little bit of a timeline. It's going to be maybe a bit uninteresting for folks that know this history, but I thought it would be interesting and useful for folks that don't kind of know the history of HIV treatment in and of itself. So up until 1986 in Canada, there really were not a lot of treatment options at all, aside from alternative medicine and complementary therapies. It was 1986 to 87. There was a clinical trial that was started, and then through 1987 it became available or approved in Canada, which is this drug called AZT. AZT is not a happy thing. AZT is a really not happy thing for a lot of folks living with HIV. One of my closest friends, who's a mentor to me in the work, swears that he is alive today only because he refused to take it for so many years. It was, however, the only thing that was available for a serious number of years. And as folks were getting sick and dying, it was often the only hope. And as an antiretroviral medication, it worked specifically there was some interest in the potential for it working. We still use AZT in treating HIV today. So one of the things that kind of happened, and I'll kind of jump to 1992, was this idea of combination therapy. So there was the Concord trials, and then a big discussion or argument happened in the HIV response, in the kind of clinical HIV response, as to whether AZT was functional as a treatment option at all, and more specifically within that, whether it could be used as a standalone drug or like single drug therapy, which we call monotherapy, or if it needed to be combined with other drugs to be effective. So this idea of combination therapy kind of came out of some questions around the effectiveness of AZT, specifically because there were so many people that were put on doses that were way too high at first and actually burned through people's livers. And trying to find an effective way of using that drug, which now I think we actually have, but unfortunately it took a long time and honestly a lot of bodies. So I'll just say that. 1998 was a significant year in terms of AIDS activist history in Canada, and specifically around this drug aerosolized pentamidine, which was approved and available in the United States, but not available for use in Canada. So there was a protest by a Toronto-based group called AIDS Action Now in May of 1998, where they had and there were treatment access conversations and protests happening kind of throughout both the US and Canada around treatments that were unavailable. And this was a significant one that happened in Canada, where they were hoping to start a trial to see if it, like a clinical trial for aerosolized pentamidine. And AIDS Action Now was like, the US has just approved it, we're all dying and we need access to this medication. Why do we need to throw bodies at this issue? We know that it works. Can't you just borrow some of the regulatory processes from the US? So AIDS Action Now staged a demonstration on Parliament Hill where I think the photo only shows 3, but I'm positive there were 4 gay men who were living with HIV that were each taking a different unregulated or unapproved medication that they had smuggled in through the US. So it was through like those types of protests and this history of AIDS activism that a lot of the medications that we now get to enjoy, that was a joke, are available. I also just want to flag a couple of things around AIDS Action Now. It's a group that's still operating, was dormant for a number of years, or not dormant, but not nearly as active as it had been in its glory days. And with some of the organizations that we in Canada get to benefit from, and in Ontario get to benefit even more from, so one would be the Prisoners HIV/AIDS Support Action Network, which is now just known as its acronym PASAN, which a number of friends of mine work for, and it's a provincial-wide organization that works with people who are HIV positive or Hep C positive or co-infected, and who are incarcerated or in the prison system or have experienced incarceration. So it's a really, really important organization that works with a particularly marginalized community. And another organization that we get national access to, which was actually originally just a subgroup of AIDS Action Now. Like PASAN started as a subcommittee, and so did CATI, which is the Canadian AIDS Treatment Info Exchange, which is now one of the 5 national partners in the HIV response. And CATI has historically been like it's the place to go for treatment access information, treatment information, and now they've gotten into the game of doing prevention work as well. And they're an amazing national organization. If you have any questions around HIV transmission, acquisition, treatment, they have a great website, and they have educators that are working on the phone all the time through 9 to 5 Canada time. You can call them and get your questions answered. So moving from combination therapy to 1996. So 1996 was a really specific year. And of course, every time I look for the data around mortality rates, 1995 to 1996, when highly active antiretroviral therapy came along, the death rates went from, and this is in Toronto, it was somewhere around 960, and then the next year was less than 50. So when we talk about, and folks may have heard this like Lazarus complex, this idea of like folks that were literally their bodies were shutting down, their immune system had kind of played itself out against the virus, and there were folks that were able to get their entire lives back, although it was really complicated when you're doing planning to die, when you're like actually planning your death, or if you have the opportunity and the time to do that, and then to be all of a sudden given another opportunity to live for who actually knows what the timeline is going to be, but a really like complex, very emotionally complex kind of situation happened around 1996 when there were some actually very significant advances made in medication. So this was when we went from combination therapy to highly active antiretroviral therapy. So specifically that was looking at the introduction of protease inhibitors. So that was a specific class of HIV medication that made itself available in 1996. And then with that, the combination of that plus some of the other drug classes really helped bring people's viral load or the immune system up, the immune response up, and the amount of virus present in people's systems way down. The last little section in terms of looking at eras of HIV treatment would be around 2006 when the first one-a-day pill came out, and that was Truvada, or it was availability in Canada, I think was, or not Truvada, sorry, Atripla. And that was in 2006. So there's a series, now there's actually like a number of co-formulations, such as like Stribild and Atripla and Complera and a couple of others that are 1 a day. So I wanted to put like a note in here between like 2001 to 4 to talk about like a lessened pill burden, but I think it's actually maybe more significantly captured in acknowledging the revolutionary aspect of 1 a day. Because when we think about what some of the treatments were around combination therapy and the introduction of highly active antiretroviral therapy in '96, that was for some people taking 3, 4, 7 pills at this time with nothing in your stomach, waiting 2 hours, and then having something with fat in it, and then taking 4 more pills, and then doing that maybe twice more through the day, and potentially other medications to deal with the side effects of those medications. So it really can't be stressed what impact pill burden had. And it's like this phrase, pill burden, gets kind of bandied about, but it's like people had to take sometimes baggies and baggies full of medication every day to stay alive. It was great that people were able to survive that and to live, but that's also like it's when you think about what the limitations were in terms of how people were able to take those medications, and then thinking about holding down work or socializing or other things. It's a really complex thing and really onerous task that I think is important to just be acknowledged. So when we get to this idea of like 2006 and the 1 a day pill, it really speaks to that very, very rapid push of pharmaceutical advancement. And we're not surprised because they're making a lot of money on those pills, so I'm glad that they're making some advances. Could I get to the next slide, please? And, okay, this is the juicy stuff, great. Okay. And while we're speaking about HIV treatment, I just wanted to say that there are currently over 30 different medications in, I think, over 6 classes to treat HIV that are accessible to folks in Canada now. That would be if you have great access to, like if your province has a great formulary and if you've got great coverage. We don't have a universal prescription plan in Canada. We have universal health care. That doesn't necessarily do a lot for folks who are living with HIV and require medications that can cost as much as $60 a pill to live. So I just think it's important to acknowledge that yes, there's a lot of medicines available, but in terms of people's access, that's another question that I think we need to be aware of. Also, tell me, I feel like sometimes my voice is slipping into like Southern dog register, so just tell me if it's like I'm hitting a pitch that no one can hear. Okay, so I'm going to do a bunch of reading, so I make sure that I'm not misrepresenting myself around this slide, because I think that this is some really exciting new information. So I don't know if people have heard in 2008. There was a Swiss statement that came out, and the HIV prevention kind of sector in Toronto, where I was living at the time, kind of exploded because people were really torn by it. They felt like it was giving a sense of permissibility to folks who were living with HIV to not use condoms, and that brought up some really strong feelings in folks that had been doing HIV work for a long time and doing prevention work for a long time. And in fact, it was not giving permission to people to do anything that they weren't already doing. But I'll read you a little bit about it. So there's a quote that I'll read you, and in it, a quote from the Swiss statement is, "An HIV-infected person on antiretroviral therapy with completely suppressed virema," so like a completely suppressed virus, or effective antiretroviral therapy, is not sexually infectious, i.e. cannot transmit HIV through sexual contact. So that's kind of what happened when the Swiss statement came out. Because we had known in doing gay men's work, and we had known in the HIV response for a long time, that you take your meds and you get healthier and you live longer, and we were seeing, as the medication was advancing more and more, we were seeing people with less complications related to adverse effects of the medications. We were seeing like lesser pill burden, we were seeing all of these amazing things. But what we were talking about, or what we heard people talking about in the communities that we were working with, were folks that had partners, or serodivergent. This is a phrase I should have put up there as well. Serodivergent. We try not to say serodiscordant because you don't want to like cast the seeds of discord into someone's relationship. So we say serodivergent, so like two different HIV statuses in the same relationship. It's a thing that happens sometimes. And we were seeing folks that were in serodivergent relationships who were having inconsistencies with condom use, or were finding it like a barrier to intimacy that they wanted to create. And when someone was taking HIV treatment, we were seeing that the HIV negative partner wasn't necessarily seroconverting, wasn't necessarily contracting HIV. And this wasn't a thing that you could ever talk about. You know, it was a thing that people would come in and access support around and be like, I need to tell you that we stopped using condoms, my partner's still negative. But like, it would always be in hushed tones. And there was never anything that you could, you know, like I wouldn't even want to say it to my supervisor for fear of, you know, like what are the implications? Like how do you write notes on that? You basically just don't. You want to support people in managing their sexual health, and you want to support people's autonomy, but we also didn't have any information. We had no evidence about this. So this Swiss statement was really significant because it supported a lot of some of the anecdotal evidence that we were hearing in community, but didn't have any evidence, like actual tangible evidence to justify. Unfortunately, as is the case for Canada at times, creating consensus around what our response is going to be took a significant amount of time. So we saw that in Ontario, and we saw that with the national partner organizations, that a response to the Swiss statement, so that like this buzzword that gets thrown around the HIV response a lot is KTE, or knowledge transfer and exchange. So we had this statement that was written in language that was not really accessible to most community members. And then all of the AIDS service organizations and national partners were trying quickly to figure out how we were going to frame this, because it's like hot potato, like someone's got to say something about this quick. But it was really divisive, and it was really difficult for folks to achieve consensus. And unfortunately, as a result of that, because the Swiss statement received a lot of mainstream media attention, so people just started applying this to their lives as if they fully understood the implications of it. One of the other things is the Swiss statement was referring specifically to heterosexual couples. It wasn't referring to gay men at all. It was talking about study. It wasn't a study. It was a statement talking about studies that had been done looking at serodiscordant couples, and there were a couple of caveats there. One was that the person had to be, or the statement is valid as long as the person adheres to antiretroviral therapy, and the effects of which must be evaluated regularly by the treating physician. So you have to take your medication, you have to take it all the time, or as it's prescribed. You have to have a relationship with your doctor that's ongoing, so that you're evaluating if the treatment's actually working. Your viral load has been suppressed below the limits of detection, so at the time was below 40 copies per milliliter for at least 6 months. So not that you just started taking medication, all right, let's go to bed, honey. And that there were no other sexually transmitted infections at the time. So, and they said that it's not 0, but it's in the range of 1 in 100,000. So 1 in 100,000 chance. So they were like, that's actually significant enough for us to say, great. But there were a bunch of caveats. But those caveats weren't getting absorbed in the general gay male population who was like, woohoo, someone just gave us permission to have the sex that we were having already. That wasn't exactly what was supposed to happen. But thankfully we get into some more other juicy scientific studies to kind of come out afterwards. So the next one is HPTN 052. And HPTN 052 came out in 2011. And I'm just going to read a couple of headlines about it. So HPTN 052 study shows 96% reduction in transmission when HIV positive partner starts treatment early. So what this was talking about was there'd been some discussion and some disagreement around when was the optimum time to initiate treatment for folks living with HIV. So some would say 350. In Canada, it was 350 for a long time. And then others were saying, oh, there's evidence out of the States that say maybe we have to follow whatever the States says. So there's evidence out of the States that say that we should start at 500 or even sooner. And what this study said, essentially, is that for folks that are in serodivergent or mixed HIV status relationships, that when the partner initiates treatment or starts treatment sooner, even before they get below that 500 CD4 count or the 500 immune response count, that there's a 96% reduction in HIV transmission or onward HIV transmission. So that was pretty significant. We were seeing almost all heterosexual couples in this study, and that was used as an argument to say that the data was non-transferable to MSM, gay men, queer male couples, although there were some gay male couples in the study. One of the things that has been challenged since that initial kind of like, oh no, you can't use this to refer to gay men, was also just acknowledging that there were a large number of heterosexual couples participating, and heterosexual couples also have anal intercourse. FYI. That's a thing that straight couples also do. And some of the data that we had around, let me hope that I put that little note in. There was, in January 2014, because I remember very well, there was an anal health webinar that I attended through the Men of Sex with Men Global Forum. And they talked about prevalence rates for anal intercourse and other forms of anal pleasure. And straight people are hitting it out of the park, I'm just going to say. So when we're thinking about how we apply this data around heterosexual sex and the transferability or applicability to transfer that information to gay men, I would say that, if and they were reporting similar levels of condom use. So I think that we could say if they're anal people, if they're straight people having anal intercourse, and the transmission rates are around the same, I think that we can actually considerably, reasonably apply that to gay men. So thankfully, we didn't have to go on just that. There were 2 other studies that have come out just in the last year that were really great. So there was a lot of questioning around HPTN-052 to say, but they had a lot of, like when you're participating in one of these randomized controlled trials, they actually had to stop HPTN-052 because they found that it was so effective that it would be unethical for keeping the control arm going, because they knew that there would be more HIV. There would be more HIV acquisition in the control group if they didn't stop the study. So it was that successful. But one of the critiques of it was, so that's all fine and good, but how does that play out in the real world? Because when you're doing a randomized controlled trial, specifically around HIV prevention interventions, and a biomedical intervention like this one, you have extra counseling support. You've got support around counseling around condom use. You've got regular medical checkups. You've got a lot, you're bolstered in your daily life in a lot of other ways, specifically around managing your sexual and reproductive health. So how would this actually play out in a real world context? So there was a study that was done. It's actually it was vigorously debated, the validity of HPTN-052, because people were really concerned about people are going to just take these learnings, take this information and run with it, apply it into their real lives. I think that as folks that are interested in research and folks that are interested in the health and well-being of queer people, so research happens, and then there's another step, and there's a step that's the responsibility of the researchers, but also the responsibility of us as community members to demand and engage in, which is how do we do that knowledge transfer? How do we do that work of taking these randomized controlled trials and other forms of research and translating that into our daily lives and into our bedrooms, more specifically. So with the KwaZulu-Natal study, what it actually was, I want to just read so I'm not misrepresenting what was going on. So it was, data was collected from one of Africa's largest population-based prospective cohort studies. So essentially it's just one of Africa's largest studies based on population in a rural region of South Africa, so KwaZulu-Natal. And it was following up on 16,667 individuals who were HIV uninfected at baseline, and then observing individual seroconversions over the period of 2004 to 2011. So basically looking at the population of this rural region in in South Africa. And it had 16,000 people that were HIV negative when the trial started. It was basically just following them. And one of the things that it looked at, or this presentation in 2013 from this cohort study, or this group of people that they were studying. So when they did this presentation or created this new piece of knowledge, was over the course of those years, access to HIV medication in a consistent way increased. So when you look at how the access to medication increased, and you look at where the new infections were happening, it was like it's actually was a really direct response to when folks have access. It's not even that you need all of these other supports. So we were seeing that when you just made sure that people had the medications to put in their bodies, that was actually significant enough to have a significant drop in HIV infections. So yeah, holding other key HIV risk factors constant, individual HIV acquisition risk declines significantly with increasing ART or ARV coverage in the surrounding local community. So yeah, like some pretty significant stuff. There's a lot of information that came out about that at that time, and I've gone to a couple of presentations by Dr. Julio Montana, who's out of the BC Center for Excellence in HIV/AIDS in Vancouver, who is a very compelling speaker, and he can speak way more eloquently around this specific study. But then he links it in very well to this next study that's actually ongoing. It's called the Partner Study. The data won't be the study won't be completed until 2017. But some of the new data that's been available. So this was through National AIDS Map, which is I think it's like quite a reputable source for HIV news, like treatment news. So their headline was, "No one with an undetectable viral load, gay or heterosexual, transmits HIV in the first 2 years of partner study. Viral load suppression means risk of HIV transmission is, quote, at most 4% during anal sex, but final results not due till 2017. So this is the thing that actually matters to gay men living with HIV, or gay men in relation to HIV.
I've often heard that study described incorrectly. You've just made the same mistake. It's
Okay.
not people with an undetectable viral load who had no transmissions. It's people with a viral load below 200, which is sometimes but not always the limit of detection.
Thanks. Okay. So I'm assuming that because it was, well, let's make some assumptions. I'm assuming that where it was written was likely where that was an undetectable state, or was it just that it was 200 and that was...
In the original course clarity, it's just 200. That
Okay.
was not really
Cool.
recorded.
Thanks for clarifying. I will double check because I just was trusting what Nan was saying. And there was actually another study or another article that parroted that, but I should dig a little deeper. Thank you. So I will just read the next part of this too. So statistical analysis shows that the maximum likely chance of HIV transmission via anal sex from someone on successful HIV treatment, so again they're not saying undetectable there, was 1% a year for any anal sex, and 4% for anal sex with ejaculation, like with an internal ejaculation, where the HIV negative partner was receptive. So do people understand, because that was that was a complex sentence, but do folks understand what that essentially was saying? So if it's a serodivergent couple, so HIV positive person, HIV negative person, and gay male couple, and the HIV positive partner is the one doing the penetrating, the HIV negative partner is the one being penetrated, that with ejaculation inside the ass, that's still only a 4% per year risk, which is again, in terms of the way that we are positioned right now to talk about HIV prevention, as opposed to even 2 years ago, the conversation is shifting so rapidly and so dramatically that I think it's really important for us to just know and to be really cautious and conscious about the language and the actual data. So I actually am going to dig on that before we leave today so that we can confirm. But I think it's really important for us to think about the impact of treatment on HIV prevention in our communities. And I sound like I'm the happiest bang the drum Stanley about HIV treatment right now. And I really am for folks that are willing and able to start and to adhere to treatment, because it's a lifelong process. We're not talking about treatment holidays anymore as they used to even 5 and 10 years ago. But we'll talk a little bit about this hopefully in the next slide. Okay, so I guess I'm going to get into it in the slide after this, but I want to talk a little bit about harm reduction. So I've been doing sexual and reproductive health education for close to 15 years. And we have a pretty standard kind of line, and it's use a condom every time. Could we get to the next slide, please? So I don't know if folks remember this Golden Girls episode. But this was basically the be-all and end-all of doing gay men's health work for the first 20 plus years of the HIV response, was condoms, rose, condoms, condoms, condoms. And it's really shifted a bit dramatically in the last couple of years in the face of these new pieces of evidence that talk about the implications of HIV treatment on folks living with HIV and folks not living with HIV on preventing onward transmission of HIV. But I want us to, can we skip back a slide? I want us to talk a little bit about some risk reduction or harm reduction strategies that have kind of become a part of the conversation and become a part of the landscape in doing HIV prevention work. I think it's important to acknowledge the role, or I think it's important to acknowledge, first of all, that exposure doesn't equal transmission. So when we're talking about HIV acquisition, I think when we look at the data around folks that are on effective treatment, and we also look at the CAS transmission guidelines, and the last ones that they put out, I think were from 2004. But the CAS transmission guidelines, we often forget, or I often forget when I'm looking at them, and the CAS stands for Canadian AIDS Society, for folks that don't know. When we're looking at the transmission guidelines, which are kind of like the Canadian Bible for doing prevention work, and it's like, these are the guidelines that we use across the country to do education work around preventing HIV acquisition. And it's difficult sometimes even for me to wrap my head around, but then also to remind folks that when we're talking about this is high risk, low risk, negligible risk, no risk, that the person who is said to be HIV positive in this dynamic is not on treatment. So that's a thing that often gets left out of the conversation. It's like, so you can lower your risk with, barrier methods are often the most common. So like condom use, condoms, rose, are like the most common methods. And then in doing prevention work, and working in a lot of cities where I was predominantly working with HIV negative gay men, in some ways I was really fascinated and appreciative that condoms were so ingrained into people's sexuality and people's sense of themselves as sexual beings that it was condoms were what you used with other HIV negative gay men, but you just didn't have sex with HIV positive gay men because somehow condoms were not going to be effective enough. It's like, that's why we were using them to begin with. The whole point of them was to prevent HIV acquisition. But it's great that you are committed to and concerned about managing your sexual health in a way that works for you and that condoms are it. But this idea that condoms are not going to be enough to prevent HIV, I think is something that we need to check in with. And around that, I also think that it's not just that we don't think condoms are enough to prevent HIV. I think it's important for us to acknowledge that there's so much fear and stigma surrounding people who live with HIV that prevents folks from being able to acknowledge what the actual evidence is around HIV transmission. And I think that's why I wanted, why I was so excited about getting to present this information, but also why it's like so much of it is actually like mind blowing, because it really shifts our thinking about our relationships historically, but also potentially our future relationships with people living with HIV. And I am inferring sexual relationships with people living with HIV in the future for those of you that are HIV negative. But within this idea of like thinking about harm reduction strategies, it was that the condoms, rose, condoms was a strategy that was working for a long time, and then there was a lot of research that talked about condom fatigue, I don't know if people have heard of that phrase, but folks that had been really successful at using condoms throughout their lives and were just finding it really difficult to maintain the motivation for that, as they were, especially as treatments for folks living with HIV were improving. We were seeing folks that were becoming HIV positive in our communities that weren't just dying, that were actually staying at work and maintaining their relationships. And that it complicated HIV prevention messaging. It became a not good thing to kind of use scare tactics about getting HIV and say, you know, like, whatever you do, don't get HIV. Because there were people in our community that were living with HIV and actually living very well. Thank you very much. So we needed to honor and respect the lived realities of folks who were living with the virus in our communities, and also often contributing to the HIV response. But we still wanted folks to stay HIV negative. We wanted folks to be able to manage that in a really complex and shifting landscape around our relationship to HIV, specifically in the gay male communities. So a couple of these strategies were developed by gay men in our communities, and then it took, as it does, years and years for the HIV response and for the scientific community to say, oh, well, maybe this is a thing that we might want to study and see how effective it actually is. So again, these don't have a lot of data around their effectiveness. They are used as harm reduction strategies, and I think it's important for me to, again, name that condoms are the most effective strategy for preventing HIV acquisition. We've just seen a lot of evidence that taking successful antiretroviral therapy is also a really great HIV prevention strategy. These are not nearly as great. These are for when folks have difficulty maintaining or achieving condom use. And some of these things work better than others. But I think it's important that we just acknowledge that there's a diversity of approaches, and sometimes you can apply one of these to another approach. So one of them would be serosorting, which is the idea of trying to sort your sexual partners so that you're having sex with only people who share the same HIV status as you. So as a prevention tool, for preventing the onward transmission of HIV, for folks living with HIV, it's actually really effective. For folks that are living with HIV who are just like, I'm not really going to sleep with negative people anymore, that as a way to prevent onward transmission of HIV, that's a pretty effective strategy. I think it could also be really limiting for people in terms of the sexual partners that they have. Not necessarily fair, but some people also feel like the stigma around trying to navigate sexual dynamics with HIV negative people can be really frustrating. So that's often a choice that's made not begrudgingly. The issue is when folks who are HIV negative are using serosorting as a strategy to then have condomless sex with, or not to explicitly have condomless sex, but to find their sexual partners and then through the course of relationships have condomless sex without a test, talk, test, trust kind of process installed in there, where there needs to be some, and not just trusting because I say I trust you, but trusting because we actually have a relationship where we've done things that disappointed each other and have had to rebuild that trust, that actual kind of trust, and HIV testing as well. We don't tend to see that as often, I think, in heterosexual or in gay relationships. I think that condom use, and there's actually, hopefully I have a link to that study, but there's a great study that I read that talked about how, what's the one word that I want to use? Foregoing condom use is one of the first things that we do to let our partners know that we care about them and that we want to build intimacy, is that we stop using condoms. And in terms of managing our sexual and reproductive health, maybe a thing we might want to think twice about. But it's also, I think, important to acknowledge that that's a thing that kind of is across sexual orientations as well. Where it doesn't always work is for folks who think that they are HIV negative and have had an exposure to HIV in the past but not been tested. So this is actually where we see a lot of new HIV acquisitions happening. These folks that assume that they're HIV negative but just weren't able to assess the risk or weren't able to access testing since that last exposure. Strategic positioning, again, is another one. You've been waiting here all night for this. So you can go as soon as I'm done. Definition. Strategic positioning is a strategy that's been used often in combination with other harm reduction and risk reduction strategies, and it's specifically about sexual positioning. So that it would be that the HIV positive partner would be the receptive partner for anal intercourse, or it could also mean that folks participate in lower risk activities, so oral sex as opposed to anal sex. And the idea is that it is easier to transfer HIV if the active partner, the penetrative partner, is positive. So if the penetrative partner is negative, that's great if the penetrative partner is negative. However, assigning sexual positions to people based on HIV status doesn't necessarily match up with people's actual sexualities. So that could be that, but you got a green card. You got a green card, so just go to the green group. You have an orange, so it doesn't always work out the way that folks want. And another one that actually it makes a lot of sense, but there's actually been some interesting research done through the International Rectal Microbicide Advocacy Network, or IRMA for short, about silicone lubricant as opposed to other types of lubricant. But just in general, lubricant is a good idea. In terms of reducing risk, and reducing risk of HIV transmission, lubricant is a good idea. You kind of want to keep your tissue supple and slick. That's all I'll say about that. Can we get the next slide, please? Okay, so now I want to get serious. So I'm just going to, I think there's maybe one or two slides. I'll just talk really, not quickly about this, but I just wanted to talk about this idea of responsibility and criminality. And I really wanted to focus this slide or two around the idea of the impacts of HIV stigma on positive men and on negative gay men. So one of the things that we see in terms of the work that I've done with gay men living with HIV in downtown Toronto is there's this thing called a Section 22 order through public health. Public health has different statutes that they're able to employ to tell people who are not doing things in public health interest to start doing them, or to stop doing things, or whatever. And in Ontario, one of those things is, or one of those statutes is a Section 22 order. And the fear of receiving a Section 22 order, which could essentially tell you to stop having sex with people, and sometimes we've seen we don't trust that you are willing or able to disclose your HIV status, or to maintain condoms, or to be sexually responsible. So the state, through the public health, will insist that a person does or does not do a certain behavior. So we have seen that the fear of having public health, and there's no statute of limitations, and there's no sunset clause on these, unfortunately. It's not like, you get 6 months probation and then you're allowed to be a good sexual agent in your community again. It's like, no, you screwed up and we're taking this away. We'll take it, hand in your genitalia, you're done. One of the things that I've seen personally is folks that I've worked with who are so afraid of the potential of a Section 22 order. I disclose all the time to my partners. I have negative partners that I use risk reduction strategies with, or only use condoms with negative partners, or are working to prevent onward transmission of HIV to other negative partners. But I have condomless sex, say, with my positive partners, because I know there's no risk of transmission. There's only 2 positive guys that I sleep with, and we get tested for STIs regularly. Except now I've heard about Section 22 orders, and I'm terrified about getting tested for an STI because the public health nurse knows that my main boyfriend is negative, so she's going to assume that I then put him at risk of getting HIV. So we're seeing folks who are living with HIV not getting tested for other STIs, not being able to manage their health and their sexual health for fear of repercussions from the state. So one of the things that we've been kind of encouraging, and there's a little bit of movement on it in BC. There's some BC nurses that do AIDS work and HIV response work in Vancouver that are pushing for anonymous syphilis testing, specifically for gay men living with HIV, but for anyone living with HIV. But they're hoping to make just anonymous syphilis testing a thing that would be available. some of the things that we see in terms of the impact of stigma and criminalization of HIV non-disclosure on HIV negative gay men, as we see, unfortunately, I see folks coming in to get tested when they're actually like not doing so well, when folks have been living with HIV for a while and it's actually impacting their immune system because they've been too afraid of getting tested for fear of criminal charges. Sometimes folks have an awareness that they participated in some activities that likely exposed them to HIV. But then if they have had partners after that, or partners during that were not that partner, it can create really complex like social and emotional situations for people. And now with Canada in the top 10 list of countries in the world for criminal prosecutions against people living with HIV for non-disclosure, it's a really scary thing. And where we had a 2012 decision with the Mabior case and the case of DC with the Supreme Court, where we saw more confusion and less clarity around the requirements of people living with HIV to disclose. We're seeing it actually go in the face of this, in the face of scientific evidence. Now it essentially says that if you're HIV positive, you have to have a suppressed viral load and use a condom, and then you don't have to disclose. Whereas the science basically says either one of those would be fine. So it's kind of going contrary to 30 years of sex ed and the HIV response, and also now a number of years of very rigorous scientific research around HIV transmission. So that's a thing that we want to address. I also think it's important when we talk about HIV criminalization and this idea of responsibility, is thinking about who is responsible for managing our sexual health. And I think that it's often been pitted as like either you are like a libertarian, it's like you are only responsible for yourself and everyone's only responsible for themselves, versus this idea of we share a community and we're responsible to each other in the community. And I think it's actually totally reasonable for us to hold both of those potentially conflictual identities and ideas at the same time. I think it's totally reasonable for us to be inherently responsible for managing our sexual health and also for caring about our partner's sexual health and our community's sexual health. I think the way that we can hold on to both of those things is by thinking about when the decisions that we make or the choices we make don't give us the results that we want, what do we do? So if I decided to not use condoms with my partner because I really care about him and I want to show him that I care about him, and I didn't, and he said that as far as he knew, he was HIV negative, and then we find out later that that he wasn't, do I go to the police as a result of that, or do we go to a counselor or a best friend's house to have a beer and maybe a little cry? So I think it's what I'm hoping that we could start talking about in queer communities and LGBT communities is that we actually have a long history of state interference and state violence and police violence on our bodies. And I'm really interested in when this shift happened, that now we call the police when things are going wrong. We call the police when things are not going our way. That's not been historically a safe option for LGBT people. And I find it fascinating that this is now an option that people are going to with more and more regularity and vigor. So I'm interested. I've got some feelings about it. I'm sure other people have feelings about it, and maybe some questions about it as well. And through a mentor of mine, David Ho, who was one of the founders of the AIDS Committee of Ottawa, and he was a mentor of mine for a number of years. He talked about this idea of creating a new community value, and I've been very lucky to have some conversations with Sarah Schulman, who's an original member of ACT UP in New York, and talking about, she's really fascinated as well and is doing some writing about what happens in our queer communities when our response is not to resolve issues internally, but is to bring issues to the state to resolve for us. So what is our community going to look like? And the last thing that I'll talk about with this idea of responsibility, personal responsibility, community responsibility in relation to or versus criminality, was the Poster Virus Project, which was launched by AIDS Action Now in 2011, which is this activist group that had been doing a lot in Toronto. And they have a Tumblr if folks are interested. I didn't put any of the images up here because it's a whole talk in and of itself. But it was a community collaboration between a number of groups working with specific ethno-racial or cultural communities, dealing with HIV within their own communities, and or specific other populations like folks that use drugs, folks who have experienced incarceration, gay, bi, and other queer men who have sex with men, to create artistic responses kind of in the spirit of ACT UP and General Idea and Grand Fury, to create artistic responses to the HIV epidemic. And that's a project that existed for 3 years with 3 different groups of artists and community members. And that's all available online, and partially to do what my mentor and friend David said, is trying to create a new community value. So thinking about how we can also push back into our communities to start discussions and start dialogue about the issues that are important to us, and not wait for media to tell us, wait for mainstream media to tell us like what our response is going to be and what our role is. Could I get the last slide, please? So this is the simpler part, except it's the long, hard part. I think that one of the things that we can do, so what's next, one of the things that we can do is we can insist on taking responsibility for our own bodily autonomy. We can be responsible for what we do with our bodies. We can take that responsibility. It's a feminist strategy as well. So you're allowed to do that. You have my permission now. And I think that we can also connect that sense of ourselves and our right to control what we do with ourselves and bring that to community. We can bring that to a group of other people that also are going to take the responsibility for what they do with their bodies, and then together, I know I'm sounding a little revolutionary, but together we can hold some people accountable. So we can look at what does the HIV response look like in St. John's, and is it actually working in a way that I need it to? And if not, I'm going to get involved, and I'm going to make it what I need it to be. We can resist the urge to involve the criminal justice system. That's a thing that we can do. We can find other processes. We can think about transformative justice models. We can think about community accountability models for how we can resolve issues, interpersonal issues, where sure, someone may have done something to you that makes you feel really awful and you think that they need to be held accountable for that. There are other ways to hold people to account other than through the criminal justice system. And putting queer people living with HIV in the criminal justice system, I think, is not a good thing. And I don't think that it's an appropriate punishment for any wrong. When I talk to the folks that I know who are living with HIV that have spent time incarcerated, getting access to medication, being queer is always, you're under threat of violence. Being HIV positive, you're under threat of violence as well. And then just thinking about getting access to medical care, let alone medication on a daily basis. And heaven forbid that you need any pain management while you're in there, or methadone, or any other medications that are stigmatized. So I think that there's a lot of other options that we can pursue when we're unhappy with decisions that other people in our communities make. I know that I'm flogging this pretty hard, but I think it's actually really important. And I also think that it's important in relation to our clinicians and our medical service providers to refuse to have our sexualities be pathologized or to be referred to only as a set of risk behaviors. That it's important to acknowledge to our doctors, and this again came from that Anal Health and Anal Pleasure MSM Global Fund or Global Forum webinar in January of this past year, or this current year, and it was talking about this. One of the problems for taboos or like anal pleasure and anal intercourse being taboo to speak to a lot of clinicians and doctors about is that if a doctor has seen any problems with it, if people are coming in and talking to their doctor about sexual and reproductive health issues, they're going to see more problems that people are having. They're not there when people want to go and give their doctor a high five because they had really great anal intercourse last night. That's not the relationship that people have with their doctors. I'm really hoping that's not the relationship. I mean, great, yeah. Yeah. Anyway, I'm not going to go there. But it's important to acknowledge that sometimes the folks that hold these positions of power in telling us what is good or bad about what we do with our bodies sometimes hear only bad things. So we need to think about what that does to their relationship to an identity that's not theirs or a practice that's not theirs. So we can hold on to that, and we can move forward engaging in our relationships with our clinicians and our care providers in ways that demand respect and also demand pleasure. And pleasure is a radical demand, but I think we have a right to it. And I think we can become involved in our communities, and that's in a number of ways. I think that is chilling out about HIV stigma in our communities. I think we've got some really useful information tonight, I hope, that we can actually bring to the next dinner party you go to, where there's going to be gay men there, or not gay men, or parents of gay men. This is actually really useful information to be able to bring into our communities. And there's lots of ways that we can get involved. That can be in more activist-y ways. It can be in more conversational ways. But yeah, all just power. Thanks.